Well, I'd like to thank everybody for coming today. I know between the holidays is always a challenging time for holding these kinds of forums and meetings, but I'm John Spertus, and with Pat McDonald and Stacy Farr, we're shepherding the QBIC, and I wanted to do the introductions for today's presentation, which I'm very, very excited about. And the foundation of that is trying to provide a little bit of context of understanding what we're trying to achieve, which is bringing multiple stakeholders together to improve the quality and value of healthcare. And this is an opportune time to be doing that because there's clearly gradual movement to a shifting payment model where instead of paying just for the amount of services we provide, such as the more care we provide, the more money the healthcare providers make, we're trying to shift to a value-driven healthcare system where we can lower costs and improve quality by developing new strategies to reimburse higher value healthcare. And the truth is that health systems, hospitals, outpatient practices, we really don't know how to do that, how to redesign the way we deliver care in order to do that. And so our premise is that if we can bring multiple groups together, providers, researchers, purchasers, payers, community, and patients, together, we will be in a far better position to develop a regional strategy to meet these evolving challenges. And so the QBIC is organized to try and support part of our community's infrastructure for improving the value of healthcare. And towards that end, we have currently two pilot projects, one dealing with opioid crisis in the emergency room, and the second on transitions in care and heart failure, where we are bringing multiple hospitals together along with community-based organizations, researchers, payers, et cetera, to try and redesign better strategies for improving care. This type of work is implementation science, trying to understand how we deliver care and create interventions to improve that. And so we also have a training program called Tiara to help equip those who are participating to better understand some of the underlying science of change management. And Tiara 1.0 was directed a little bit more at the research community. We have a second generation of training programs in short snippets that we hope will be of great value to the providers as well as researchers and community-based organizations. Our stool are these forums where it's an opportunity to share collectively different perspectives and think about how some of what's shared could be employed to improve the way we deliver care and can inform new projects, not only the two we currently have, but future projects down the way, which we hope will be projects 3, 4, and 5 over the upcoming years. Now, all hospitals have embraced the concept articulated by the Institute of Medicine of being a learning healthcare system, trying to learn from the way they are delivering care, how they can improve that care delivery and improve outcomes. And in Kansas City, we have multiple hospitals that are all engaged in this. And what we're trying to do is to share strategies and insights so that we can become a learning healthcare community as opposed to just a learning healthcare system. And we take input from multiple stakeholders in trying to design and improve our initiatives. And these include, healthcare leaders and providers, community-based organizations, researchers, purchasers, payers, philanthropy, policy, industry, public health, and professional societies. But at the center of all of this are the patients. And today's forum is really focusing on the patient perspective. And so we have a remarkable group of speakers today, and I'm just so privileged to be able to introduce them and to hear what they're saying. The first is Harlan Krumholz. Harlan Krumholz is really an international authority in quality and outcomes research. He's an endowed professor at Yale, a member of the Institute of Medicine, and he's somebody who's really known for his innovative and creative thinking. And it's a tremendous privilege to count him as a friend and colleague for over 20 years. and he'll be talking to us about empowering and engaging patients to collect, understand, and use patient-reported outcomes as a toolkit in trying to think about how we optimize the quality of healthcare. From the community-based organization perspective, we're very fortunate to have Mary Kay O'Connor and Philip Duncan. I've known Mary Kay for well over a decade. She's an entrepreneur who really is trying to elevate our understanding of patients' perspectives of clinical care and how providers can leverage that to improve the care they deliver. From the patient researcher perspective, we're very fortunate to have Catherine Martinez, who's a PhD that trained in Hopkins and is now at the Cleveland Clinic and the Lerner College of Medicine. And she's been a patient herself and has evolved to really be focusing on patient-centered decision-making. From the provider perspective, we're very fortunate to have Lindsay Milner McNeil from St. Luke's Hospital, who's leading a lot of our efforts in transforming healthcare based on patient experiences. And she'll be talking about patients experiencing motivating transformations in healthcare delivery. And then we will have a discussion led by Stacy Farr. Harlan Krumholtz has another obligation. So we will take a brief pause after his perspective for discussion, and then we will move on to the rest of the presenters. If you have any questions, please take advantage of the chat function in Zoom so that you can share your ideas, and that could be used as a seed for further discussion. So at this point, it's really my privilege to request Harlan to take over and to share his presentation. Thank you so very much.
Yeah, thanks so much, John. It's my pleasure to be part of this, and I really think that Kansas City is so fortunate to have you there. You are truly a leader in this area. You've given voice to patients. You've created instruments that codify their perspective and incorporate them into everyday practice in ways that we'd never imagined before. You were able to do that. So anyway, it's a great privilege to be part of this, and also you've taught me so much about this. So folks, everything I tell you now, John could have said, probably said better, but I'm glad to take a shot at doing this, because I'm a real advocate for bringing the patient voice mainstream into care, and believe that if we do it with these kind of structured instruments, these tools, that they will propel us to ever more give that voice a greater meaning and consequence, and will help us do a better job. So let me just say, I titled this, I know I was given a thing, but patient-reported outcomes, high tech meets low tech. And let me explain a little bit about what I mean by that. So the premise is that patient-reported outcomes are a powerful tool for decision-making and treatment. And I sort of call this low tech. I mean, low tech because it's high touch. It's about talking to people. It's about listening to people. It's about bringing forth their perspective. And then what John did was help catapult the field into a whole new area by making tools that really standardize the way in which we could bring that information forward. And now technology enables their easy deployment. So there's nothing that should be holding us back now. That's where the low tech meets high tech. But, I have this question: why patient-reported outcomes don't get more respect? I was going to put a picture of Rodney Dangerfield here, but then I thought maybe only some people like of my age really know who Rodney Dangerfield is, but he's a comic who sort of made this part of his shtick. But I actually don't know the answer to this, except that the business models don't really respect or reflect the value of what the patient-reported outcomes do, because in any reasonable world, they should get a ton of respect. They're inexpensive, easy to understand, readily accessible, actionable, and intrinsically patient-centered. And this should be what we should be tacking to. And by the way, low risk. I mean, I can't even imagine anyone getting harmed from participating in something that produces information about how they're feeling. And so there's lots of reasons to recommend them, but they're not complicated, expensive, or mysterious. And in healthcare, we like to really adopt those things, that maybe seem like they're really complicated and highfalutin. And so that's maybe the problem. They're also an issue, like I said, about the business model in medicine, not really bringing a particular company who's promoting them and who has a big margin as a result. I do want to say that not all patient-reported outcome tools have the same quality. So when in this talk, I'm focusing on those instruments that have exemplary performance as measured by their construct validity, internal consistency, test, retest, reliability, and responsiveness. I only say that because the premise of this is not like any instrument, not any patient-reported outcome, but the use of tools that are truly validated and that we can have confidence in, that are producing information that's consequential. So there is this little caveat here. It's endorsing the notion that we can bring the patient voice in with these instruments, but it doesn't apply necessarily to anyone that someone would throw out there. But there's a difference between those that are really good and not. And there's lots of examples already in the literature where these have consequence. Knowing what patients are experiencing, understanding this in structured and repetitive ways can improve outcomes. It can sensitize us to issues that they're facing, experiences that they're having in ways that our usual care doesn't really capture. In usual care, we're either only capturing things within the office visit, but often, depending if it's in the morning or afternoon, if we're tired or if we're not, we may not be asking all the right questions. By using these tools, which systematically are collecting information, and often outside of an office environment, we can collect information that can improve outcomes. This is an example of a study. Many of you have seen this, where an oncologist, Ethan Bausch, that I have great respect for, is at UNC, showed that if you systematically collect information from patients about their symptoms, these are patients with metastatic cancer, that their survival was better. Their survival was better. And again, we have a lot more research to do, a lot more testing, a lot more understanding about how this goes. But what they said was integration of patient-reported outcomes into routine care of patients with metastatic cancer was associated with increased survival. So many cancer studies are just looking at whether the size of the tumor shrinks. They're looking at surrogate outcomes. They're trying to see, are there changes in the tumor? And we keep asking them, like, that's great, but what we really care about is, what about outcomes from the patient perspective? This is an example where we were seeing this association, 17% lower mortality risk. Now, again, needs to be validated. We need to test it further. But if you had a drug for people with metastatic cancer that was going to improve survival, 17%, we would all be celebrating that was a great breakthrough. They opined about mechanism, potentially early responsiveness to patient symptoms. The nurses responded to symptom alerts 77% of the time with symptom management counseling, supportive medications, chemo dose modifications, and referrals. And this may have resulted in better tolerance of chemotherapy. The people who were being monitored with these tools actually were able to stay on chemotherapy longer. And it's likely it was because of the attentiveness to the experience that they were having. So I next want to go to another paper that came out recently, and there was a very famous first author here. I can't quite read his name, but many of you may recognize that first author. But in this case, John is leading a group where really asking the question, would knowledge of people's symptoms using a standardized instrument. Again, if I go to a bunch of doctors and say, you should really talk to your patients to understand their symptoms, they're using all sorts of different questions. There's very little reliability between the individual physicians, and even within a physician, like I said, morning to evening, and the tone of their voice, the way they're asking the questions, it can affect what people say, even whether they feel open enough to express how they're feeling. But these instruments, such as the one that John has created, provide the opportunity for people to complete standardized tools that produce information. And what John was able to show was that on this in this case, the Seattle Angina Questionnaire, a pioneering tool that he developed, which was able to score people's symptom burden on a 0 to 100 scale, this is showing is the effect of an invasive strategy, effect of putting stents in people versus medical therapy, depending on what their symptom score was. And so when you see that, like at low scores, which is high burden, that you can see that numbers up around 15 and 10, those are big gains in quality of life, essentially, at 3 months, 12 months, 36 months. And as it comes down to 0, you see as people have fewer symptoms, less burden, the benefit of the intervention is less. It matters how people feel. And you get a lot more bang for the buck for people who are severely burdened than people who aren't. But again, by using these tools, we can standardize this. We can make it so anyone can do this. People can do it in their home. People can see this. It can assist decision-making. Whether you opt for an invasive therapy, whether you opt for a stent, should be importantly related to how you score on this test. And right now that's not happening in a widespread way, but he's showing in this New England Journal paper, one of our best journals, that there's a strong relationship between how people respond to this questionnaire and what they're likely to get out of the intervention. So in disclosure on the first slide, I said I've sort of been a co-founder of a company that's seeking to make it easy for people to gain agency over their data, to be able to pull their data together from different sources. But one of the things we're working on is we want to make it really easy for people to fill out these forms, be able to get a hot link, they hit on it, they get it on their phone or on their tablet or on the computer. And it's seamless and frictionless. And we're not the only ones. Lots of people are doing this. I'm not trying to sell anything. I'm just trying to show where the world, I think, is going. I think these are very powerful tools that are underused, and that we can start to make them mainstream if we actually go direct to consumer, help people start tracking their own information. And, we've got these so that you can have sliders or people can point where they've got pain. We have an opioid project we're doing with the FDA with this system, where we're asking people when they leave the emergency department, tell us where your pain is. We ask them repetitively over time, and we're tracking it with what opioid prescriptions they might or might not have gotten. We can apply tools like John. So I think this is where the world's going, which is, we're going to get more information coming straight from the patient in standardized ways so that we can score it and understand it. Here's an example of a project we did at Yale that John was involved in that was looking at recovery after surgery, using this tool, using these mobile devices to collect information. And what we're able to do is make a dashboard. Now, I know there's a lot to look at and my time's almost up, so I'm just going to say quickly that we were able to take mostly questionnaire data, mostly PROM, patient-reported outcome measured data. And at the bottom, you see steps by Fitbit. And we were then able to create subscales about how was someone recovering after open heart surgery. And from cognitive, physiologic, nociception, including nausea, pain at the incision site, dizziness, activities of daily living, emotive, that was depression, restlessness, lonely, sleep. And this was all those top 6 are self-report, but by tracking them over time, we're seeing, are they making the kind of recovery that we expect? Are they hitting speed bumps? Should we be intervening? Where is it that they're feeling better? Where is it that they're feeling worse? And then by integrating in wearable data, we can also look and see how long does it take them to start their activity to get back to normal? We could, bring them into the office and ask them. They often can't remember. This is actually in real time collecting information. This, I believe, is the future. We can be doing disease management. They can be looking at this. They can share this with their loved ones. Of course, we can improve the dashboard so it's more easily even interpretable. But again, very valuable information. As valuable as almost anything else we're doing. They can stop in and we can do objective testing. But I think this is objective reflection of how they're feeling. We were also looking at this and seeing that patients could be divided into particular groups based on their outcomes. People who had persistently high or high and declining or low and declining work. This is based on recovery, but that people start to cluster in different groups, and we can start to understand who are these people who are declining in their function and experience and quality of life versus people who are improving. And this will open up all sorts of opportunities for discovery about what we can do for interventions. So, the bottom line here is what I'm trying to say is I think it's time to reconsider the role of patient-reported outcomes in medicine. What I mean by that is we have them, we're using them in studies, that we're not using them enough in everyday practice. We're not making them mainstream enough. And I say they can be a powerful adjunct to care, a means of improvement and accountability. And so many things depend on how people's experiences. If we're not measuring it, if we don't know it, we can't be seeking to make it better, and we can't be accountable for it. This is what it can do. This is a way to bring the patient experience into the mainstream, a strategy to meld old school caring medicine, listening to patients, with newfangled approaches to implementing decentralized care solutions, more precise and individualized care plans, higher value and better health outcomes. I'm convinced of this. And so, I want to just say thank you for this opportunity. It was only 10 minutes. I hope I haven't gone over, but it's the notion here, I think, is there's a world of possibilities in this low tech, high tech thing that, we're not waiting for the next new drug, or we're not necessarily waiting for new lab tests. This is something we can start implementing immediately. And I think transform the way that we are listening and acting on information from patients. So thank you.
So Harlan, thank you so very much. As as always, listening to you is like drinking from a fire hose. And what I want to
a nice, delicious fire water from a fire hose. Yeah.
Well, there's a tremendous amount of richness. I mean, you've shared with us, that the power of these tools to understand patients, to actually improve their survival and care when used in conjunction with cancer chemotherapy treatments. You've raised the issue that they're simple, they make a lot of sense, and yet they aren't fancy, expensive technology. So we seem to diminish their value because of that. And what I was wondering is, what do you think is the critical barrier to actually having these used more, given their low cost and high value? And from my perspective, I've always believed that it was the fact that we aren't paid for it, right? That payers don't pay for the effort to invest in an infrastructure like Hugo to collect the data, to invest in the informatics it takes to put it into your own EMR, to invest in the training of the doctors to understand what these things represent and leverage them in their care. And the failure to pay for the collection, scoring, and interpretation of this is why it's not embraced. Whereas, something like an EKG, far more expensive to acquire the equipment, far less informative in most circumstances in guiding care, does get reimbursed. And so can you correct me if I'm wrong, that it's the failure to reimburse for this that's a principal barrier, or there are other barriers that you see that are preventing the adoption of, when you present it, something that seems so obvious?
Well, I mean, I think that clearly the business models affect what gets adopted to a great extent, but I believe that the use of this, if we can find places like yours that, and having you there is such a great opportunity for the Kansas City community, where I believe it'll be a competitive advantage. The patients will like the opportunity to have their voice heard, that their outcomes will be better, the value will be promoted, and it'll be done so in a way that at the margin doesn't require a great big investment. But part of it is we have to reflect what that is. We have to be, clear about what the return on investment is for patients and for the system by using these. But yeah, I mean, I think that it's not going to be fixed either by just saying you're going to pay for it. We have to change a culture. I mean, I've always thought that these tools are next generation history taking. I mean, they're basically being able to refine what patients say and put them in terms that can be summarized, organized, and tracked over time in ways that help us to hone our approach. And so, I mean, I think it's a matter of trying to get some prototypes up. That is, it's not prototype of the instrument. I mean, prototype of a system that integrates this in. Now, the orthopedic surgeons have done this from time to time, and there are others. Ethan's doing it, others, and you're going to hear more about this, I think, in the subsequent talks, but not enough. And we need to, I think, try to put our foot on the gas and say, it's time to really give this a full run and tell the story a little differently than we have. These aren't just surveys. These are strong, validated tools that provide actionable information that can fundamentally shift the way that we provide care and improve our sensitivity to what patients are experiencing. And we need to start telling the story in a different way than the way people commonly understand, like, yeah, these are just surveys or these are research instruments. Anyway, that'd be my view. I know I don't want to take too much time, but thank you, John, for
look,
that.
It's great to have the discussion, and it's unfair to do this, but I'd love to pick on Tony Sun to comment on this a little bit. Tony Sun is the Chief Medical Officer of the Midwest region for United Healthcare. And I'd be very curious, Tony, do you envision a future where these tools are supported for monitoring or caring for patients, or that United might consider reimbursing differently for better improvements in patients' health status, or even not paying for something like bypass surgery or angioplasty in somebody who has no symptoms, given the data that Harlan showed, which suggests that they don't obtain either a quality of life or a survival avoidance of acute myocardial infarction advantage from going to the procedure. Like, why are we paying for procedures that don't provide any value and subject patients to risk? And do you think the payers will ever step up to be sort of accelerants of the use of the patient's voice in healthcare?
Well, the short answer is probably yes, right? I'm a big fan of both your work and Harlan's work. Great to see you, Harlan. I really wish we could accelerate something here in Kansas City. I would like to ask all the participants as well as, how we can farther nudge. I think that recently, during the National Academy of Medicine discussion, I talked about, there was various discussion about the nudge and sludge, but we need the patients to be part of this as well as the providers to embrace it. All right, so that's the critical part. I would love to have, for example, if a unnecessary procedure was done where this instrument would have been in play to make that a cost trade-off discussion. But I don't think I would say the provider, especially the financial portion of a health system, have the appetite for that discussion yet, okay? But I think when patients demands it, perhaps. But I just don't see that. We would love to have that conversation with them. And I often joke about the fact that if something was done unnecessary, we should not only get a rebate, we should get an apology letter. Right? So, but I know we're not there, but the culture of that change needs to be louder. And I totally echo what Harlan said. I would love to continue to utilize Kansas City as what I call the Framingham of PRO. I think that would be phenomenal. Again, thanks to you, John, and the work you all are doing, Stacy, and all the staff, Patricia, you guys are doing, along with BioNexus. Yeah, well, you got me as at least as long as I still work at United, I'm going to continue to champion that. And I would invite both you and Harlan to really talk to, some of our R&D folks to see if there's something here that we can, put some guardrails or structure around to do more. So,
and I just say that you can count on me to help. I'm all in on helping in any way I can. Kansas City would be a wonderful place to do that. I think, Tony, the other thing is it may be not in R&D, but let's do pilots. Let's try to build something out, see if we can actually build it into the ecosystem in a substantive way. But anyway, whatever I can do to help you all, you can count on me. I'd be glad to.
Thanks so much. It would be very exciting to have, Kansas City be an alpha testing lab for some of this work. And I think there's a lot of passion for those on the call and throughout the entire QBIC to make that a reality. Well, Harlan, thank you so much for your time. I think we could all listen to you for a long time, but we have some spectacular additional speakers. And next, we're going to be hearing from Mary Kay O'Connor and Philip Duncan on patient perceptions of clinical care and its role in thinking and redesigning healthcare systems. So, Mary Kay, if I could turn it over to you, I'd love to.
Mary Kay, you're muted. You're muted.
Okay, there we go. Can you hear me now?
Yes, yes, we can.
Okay. I'm Mary Kay O'Connor from Patients Voices. I'm here with Philip Duncan, our Chief Data Scientist. We are an early stage healthcare technology company. Our technology has been developed based on 5 rounds of funding from the National Science Foundation. And what we have developed is a next generation AI platform that can recognize and classify patient feedback. It is not a text analysis tool. I'll give you examples of how it works. But we classify and label what patients say about their experiences, and then we can convert that into very precise analytics that allow us to set priorities in terms of what are the issues that health systems need to tackle to improve the patient experience and the patient ratings of the healthcare system. And we can do this by department, by type of patient, et cetera. So I'm sorry. Okay, so I have two wonderful partners. Philip Duncan is here with me today. The second person on the team is Joe St. Amand. He's our Chief Technology Officer and a wizard at AI technology and all of the underlying tools that we use to do what we do. Our target is large integrated health systems, and we have several under contract currently. So I recently read an article in HBR by John Glazer, and the article was about principles for improving patient experience. And John believes, as do we, that patients have become consumers. And what does that mean? Increasingly, they are choosing where to go for care. And there was a wonderful quote in his article. He said, today's health systems must provide great medical care and a terrific consumer experience to get the nod from the patients that are walking in and out of their health system. And so how do you deliver a terrific consumer experience? That is indeed the challenge. And let me say before continuing that today, health systems predominantly use surveys. They're ubiquitous. And they're really important because they provide important benchmarks for health systems, but they are difficult to use as a tool for improving the patient experience. If you look at national HCAHPS ratings, the overall rating hasn't improved since 2016. Now that doesn't mean individual hospitals aren't improving, but in general, it is a struggle to use the existing tools without supplements to improve patient experiences. If you consider a patient who receives a survey and is asked to complete it, they go through and systematically rate the questions as expected. But when you ask a patient to rate individual questions, what you're doing is you're foregoing asking them about what was top of mind after they completed a recent healthcare encounter. What went well, what didn't go well, and those are the things that really help you understand what patients are experiencing in a way that you're able to fix them. And so what we recommend is instead of using survey ratings, that you simply ask patients to tell their story, tell what happened to them. And by doing that, you get tremendous understanding about what they did encounter and lots of details, which is actually the prescription for improving their experiences going forward. So that's the piece that Patients' Voices does. Fixing the problem, we believe, is best handled by quality resources within the health system. And that's one of the reasons why we were very excited to be here, because we think a partnership, our experience has been a partnership with quality teams really can have a tremendous impact on both the patient experience as well as the health system ratings. So just a little bit about how our system works. I'm going to describe something that's completely different probably from what you're used to. but bear with us and we'll show you some results. It's a 3-step process. We collect feedback, classify and label the comments, convert the comments into analytics and display it in a dashboard. So the collection process is pretty straightforward. Once a patient has completed an encounter, whether it's inpatient or outpatient, they receive a direct message from the electronic medical record. We receive a direct message from the electronic medical record and send the patient either an email or a cell phone number, and we send them a link, and the patient clicks on the link and provides their feedback. They're prompted with just 2 questions: describe your experience, and on a 10-point scale, rate it. They hit submit, the feedback comes back to us, unfiltered, unbiased feedback. The next step is we run the comment through our AI platform. This is the same comment that you just saw on the cell phone. As you can see, there's a couple ideas here that the patient's expressing. The doctor didn't do a thorough assessment, went to my primary care physician and found out that I had pneumonia, which they didn't even talk about yesterday. It's so frustrating. So that's a patient talking about their clinical care and the diagnosis. We intentionally used a negative comment here, but I want to be sure to call out the fact that the majority of the comments that we receive from patients are extremely positive. Patients really appreciate the care that they receive from their health system, but there are issues, and so that's what we tend to focus on today. The second area is this particular patient was complaining about the communication of the doctor. The doctor refused to listen to my concerns. So we take these comments once they've been classified and labeled, convert the comments based on how frequently certain themes come up and the sentiment of the comments, and convert those comments in using algorithms into the data analytics that are then displayed in dashboards. We can show the frequency with which topics are talked about. In our world, blue is positive, orange is negative. Real-time comments can be converted and displayed in dashboards within 24 hours. We can peel out service failures when a patient has a really bad experience, decides to go elsewhere, leaves without being seen. We use a lot of statistical modeling to identify what types of comments are having a particularly negative impact on the patient experience and ratings. The lower right-hand corner shows how closely our average sentiment tracks the overall rating of the health system. So it's given us a lot of confidence in the accuracy and the validity of the data. I'm going to turn things over to Philip Duncan. He's going to talk about and give lots of examples of the type of feedback we receive from patients. I know when I first started this work, I heard CMS talk about the fact that patients really weren't in a position to comment on their clinical care. What we find is it is among the top 5 topics mentioned by consumers. And if you think about it, it makes sense. They go to health systems to receive clinical care. It is a very important part of our work, but equally important is patients don't, you'll see this as Philip starts to describe what happens here, but patients aren't commenting on on necessarily how treatments are administered, what medications are prescribed. That's not where they come from. And you'll see that as Philip shares some of this data with you. Philip?
Yeah, I know we're probably rushing on some time, so I'll try to go through this quickly, but we, feel it's important as kind of a dual empowerment where patients' stories are able to be shared, and at the same time, providers can get access to wide amounts of data without having to manually like go through and analyze the comments themselves. And so part of what we see is like really treating patients as consumers and delivering excellent experiences to really let them lead the conversation, which means allowing them to talk about the things that they might want to talk about, which might not be things that are typically asked about. In clinical care, we see as one of those things. And as Mary Kay mentioned, sometimes that reveals that their perspective on what clinical care is or what any of these topics is might be different than from what's within the healthcare system. And we try to be transparent about that, be pretty patient-centric all the way down, and allow their voices and their perspectives to come through kind of as they see them. So if Mary Kay, you want to go to the next slide, we won't go through all these. We've got some samples of comments, but for example, with diagnosis, a lot of variation on people talking about getting the wrong diagnosis or feeling that they didn't get thorough enough evaluation, or that they needed to be sick, or their view wasn't important, for example. Mary Kay, if you want to go to the next one, where we've got some samples on clinical care tests.
Sure.
People talk about things like wanting to get more testing, wish that they could get tests that were refused to them, thought that the exam didn't go the way that they wanted it to be, or in some cases that just the way that the test was done was improper. Coordination is another theme that kind of comes up a lot, and we see a lot of diversity with these comments as well. If you want to slide through the next one, Mary Kay, where people talk about how providers maybe aren't looking at and coordinating and talking with other people on the provider team, or having some cases having the wrong patient, or a lot of cases having miscommunication among providers that leads to a lot of difficulties. And in all these things, that the purpose of us sampling all of these, like I said, not to go through them all, is really just show that there's a lot of power we feel in patients being enabled to provide their perspective in an unbiased way, so that these tips can be utilized to provide a blueprint for people within the health system to implement strategic changes.
One thing I want to point out, and let's take the diagnosis category to begin with. Just because a patient says what they diagnosed me with was wrong doesn't mean that that's actually the case. We believe that the communication or the patient's understanding of what was communicated in a lot of times contributes to the perceptions of what went on. The same for test results. They feel like they've been gypped because they didn't get a test result. This diagram here on the right-hand side, it shows the correlation between the overall rating and the average sentiment. And we typically suggest that clients focus on the types of comments that appear in the lower left-hand quadrant, because those are the types of experiences that are having the greatest negative impact on both the patients and the hospital and its ratings. So just one final note here. We've been working with Children's Mercy Hospital almost since the beginning. And this shows the results of the work they've done over time, and as we have provided them with the details on the feedback from their patients. So we have a lot of confidence in this approach, and want to emphasize that we think there's a lot of value in terms of using the tools we have developed in parallel with the benchmarking. It gives the quality teams and the health system a really bird's eye view of where the issues are and what they need to work on, which is especially important right now, given the loss of personnel from health systems. Being able to really identify what are the priorities that are having the greatest negative impact on patients, knowing what those are, really puts a lot of power in the hands of the quality team. Anyway, we'd be welcome to answer any questions you might have.
Great, thank you so much, Mary Kay and Philip. That was really excellent. And thank you for the work that you're doing. If anyone has any questions, please do put them in the chat. I think in the interest of time, we're going to keep moving the agenda along for now, and we'll save the final questions for the end. But our next speaker will be Dr. Katie Martinez, and she is assistant professor and associate staff at the Cleveland Clinic, Lerner College of Medicine, and a friend and former colleague from our time together at Hopkins. And, you know, I'll let her tell her own story, and I won't spoil any of the story, but she's really focused, driven by her own experiences in healthcare and kind of the research and her area focused on shared decision making and the patient voice. So I'll turn it to you, Katie.
Thank you, Stacy. So today I'll be talking about using patient-reported outcomes for complex decision-making in cancer. First of all, thanks to Dr. Farr or Stacy for inviting me to participate today. I found this was a surprisingly hard slide set to compile. Yes, I was a patient, and yes, I have used patient-reported outcomes in various ways across my career, including getting a dissertation award in patient-reported outcomes. But this talk was really a great opportunity for me to reflect on how these two experiences fit together as both a patient and as an academic. So we can start at the beginning. Way back in 2006, I was diagnosed with invasive breast cancer when I was 27 years old. I had no family history, and I'm BRCA negative. What followed was 4 months of dose-dense chemotherapy, a year of Herceptin, and 2 years of hormone therapy. This is a picture of me at my last chemotherapy infusion. I may look kind of poisoned and bad, but I was really happy. But at the time of my diagnosis, my prognosis was very unfavorable. Literally, my pathology report had the word unfavorable written all over it. I was way too young, and I had HER2-positive disease. Luckily, after 2006, the FDA's approval of Herceptin for early-stage cancer changed that. It was actually approved on the day I was diagnosed, on November 15, 2006. However, at the time, because my prognosis was so unfavorable, I found I had no role in decision-making. One medical oncologist actually said, if you don't do exactly as I say, I guarantee you won't be alive in 5 years to tell me I was wrong. This was my entree into very bad patient-centered communication. But one decision was up to me. The decision between lumpectomy plus radiation versus unilateral mastectomy is considered preference sensitive. This is because the risk of the key outcome, which is survival, is the same regardless of which one you choose, but the trade-offs are different. There's also no difference in survival between unilateral and bilateral mastectomy, which was also an option for me. I was given 5 weeks to make this decision entirely on my own. One thing I reflected on as I was making this presentation is that my relationship to PROs is informed by my experience of being an outlier. Less than 0.5% of all breast cancer cases occur in women under 30. And most of what is known about breast cancer treatments and their impact on physical and psychological health is drawn from women in their 50s and 60s. Those of us who aren't means or medians are very suspicious of means and medians. So what do the numbers represented in patient-reported outcomes actually mean to me as an outlier? Getting back to this decision I had to make, I just want to spend a minute or two laying out the differences and the trade-offs I was considering. There are differences between unilateral mastectomy and lumpectomy with regard to pain, the need for reconstruction, and potentially the need for prosthesis. With lumpectomy, I would also have to consider the impact of radiation, which would include 35 daily trips to the hospital, the short-term impact of burns, itching, and exhaustion, and the long-term impact of leathery skin, which would limit my future surgery options. But I also had to consider unilateral versus bilateral mastectomy. This comes with even more trade-offs related to pain, recovery, risk of a future new primary breast cancer, impact on potential breastfeeding, and need for future surveillance like mammograms and MRIs. My doctors were like, well, which do you prefer? And I found my strongest preference was to not have cancer and to not have to make this decision at all. But what I also found was it was hard to have preferences for health states I had never experienced. I definitely prefer having a cold to having the flu because I've had both. But I've never had major surgery. I had never lost a body part. I had never had a new body part reconstructed. And most of all, I had never lived with the permanent consequences of a medical decision. When you don't have experiences of your own to draw on, you can draw on the experiences of others via patient-reported outcomes. There are two primary ways that patient-reported outcomes can assist here. First, they can tell you how likely different outcomes are. For example, 30% of mastectomy patients reported pain at 3 months compared to 10% of lumpectomy patients. And they can also tell you how people feel about the outcomes, like health-related quality of life scores are higher for patients who opt for immediate versus delayed reconstruction. This information is extremely useful when facing life-altering decisions. Here's a study out of the Annals of Surgical Oncology that aimed to generate exactly such data. They generated patient-reported outcome values to support women's decision-making for breast cancer surgery. They surveyed 612 women with a median age of 51 years who had undergone 4 different surgical procedures to understand various health-related quality of life outcomes, including satisfaction with breasts, using a scale called the BreastQ. They did find statistically significant differences between the 4 procedures. Those with mastectomy and implant reconstruction had the lowest satisfaction, and those with mastectomy and tissue reconstruction had the highest. The study would be super helpful if the only thing I cared about was satisfaction with my breasts. Go for mastectomy with tissue reconstruction, absolute no-brainer. But people generally care about multiple dimensions of a decision. Mastectomy with tissue reconstruction has a long recovery time, high risk of infection, and I couldn't breastfeed. So for this, global decision-related patient-reported outcomes may be more helpful, specifically measures of decision satisfaction and decision regret. So when considering a decision with long-term consequences, we do a thing called effective forecasting. Essentially, it's a consideration of how future you will feel about the decision made by current you. In my postdoc, I studied whether surgical regret after treatment for localized breast cancer changed over a 5-year period. We found it was both low and stable over time for all surgical decisions. So this kind of information is useful for patients to know that how they feel about their decision today is likely how they're going to feel about it in 5 years. But a major caveat with decision-related patient-reported outcomes is that differences in satisfaction and regret are generally more variable between individual people than the decisions themselves. This variation has been documented by patient age, race, educational level, whether or not the patient participated in shared decision-making, time since the decision was made, although we did not find this, there are other studies that have, and importantly, side effects or late effects associated with the decision. People with worse outcomes regret their decisions more. But does this mean the decision was the wrong one? I don't have an answer for that. Moreover, the trade-offs associated with different risks and benefits varies by individual. When I was a 27-year-old making this decision, I had a good job with generous benefits, a supportive partner, I was in overall good health, and I hadn't had children yet, and I wanted to breastfeed. I also wanted to look good in clothes. If you flip my age to 72, which is a very common age to get breast cancer, I would potentially be retired, maybe without a partner, definitely with some comorbidities, done with kids and breastfeeding, and maybe I wouldn't care as much about looking good in clothes. But importantly, the amount of time I would have to live with the consequences of my decision varies by decades. This will obviously impact my relative valuation of different health states. Both disease-specific and decision-related PROs are essential for informing complex decision-making, but they're not sufficient. We need to contextualize for patients whether the PROs were drawn from patients similar or dissimilar to them. Methods to help patient weigh competing trade-offs involved in a single decision are needed, particularly those that can take into account individual patient values and preferences about those trade-offs. Conjoint analysis approaches like discrete choice experiments are very useful for this. By asking patients to select between bundles of trade-offs, these exercises can reveal to a patient the features of a decision that drive their preferences. Here's an example of a discrete choice experiment for breast reconstruction. As you can see, option A has a similar long and short-term complication rate, but only good aesthetic result. Whereas option B has a much higher long-term complication rate versus short-term complication rate, but better aesthetic results than option A. Choosing between the bundles of options can help patients understand the component of the decision that they care about most. Yet these have been minimally implemented into decision support interventions in practice. I was lucky enough to have the opportunity to conduct one of these myself. This is a rating-based conjoint analysis where women were asked to rate a number of different scenarios regarding chemoprevention, including risk of hormone symptoms like hot flashes, risk of blood clots, and how long they would have to take the pill for it to work, or how likely they would be to take tamoxifen. And they rated 36 of these scenarios where we varied each of the attributes each time. And they rated it on a 10-point scale. So patient-reported outcome studies show that hormone symptoms are very bothersome to patients, and that might be the reason why patients decide for or against tamoxifen. And indeed, that was our hypothesis. We thought that hot flashes would be the main thing that drove patient preferences for or against taking tamoxifen. But in fact, on our study, we found the risk of breast cancer and the time needed to take the pill drove patient preferences. So this is a good example of why these sorts of bundled preference elicitation strategies are really useful. If you just took the PRO on its own, you might say, absolutely, it's the side effects, but truly people are weighing multiple components of a decision when they develop their preferences. In sum, decision-making is hard and requires patients to evaluate their feelings regarding numerous trade-offs. Patient-reported outcomes can help inform patient feelings about potential trade-offs, but may not be sufficiently individualized for patients outside the norm, like me. High-quality decision-making must include a consideration of patient values and preferences. And while it's easy to know your preferences for positive states, like going to the beach or the pool, it's much more difficult to formulate preferences regarding competing negative states, like different ways of losing a part of your body. So what did I decide? I opted for the bilateral mastectomy with implant reconstruction. The medical oncologist said, "You made the right choice." This was infuriating because I was told that there was no right choice, and I labored over it for 5 weeks to figure out what the right choice was supposed to be. If there was a right choice, they should have just told me. Am I satisfied with my decision? Sure. Do I regret it sometimes? I do. But I had an easy time. I went wine tasting 3 weeks after my mastectomy. I had friends who spent time in hyperbaric oxygen chambers for mastectomy incision wounds that wouldn't heal. How can we interpret patient-reported outcome measures that lump us all together? So based on my experiences as a patient, I wanted to improve the decision-making process for others. I spent the 7 weeks of short-term disability after my mastectomy studying for the GE. I crushed it and got into Hopkins with Dr. Farr. I did my dissertation on disparities in patient-reported cancer pain, working with Sydney D and Claire Snyder, who is a big vanguard in patient-reported outcomes. And I then went to do a postdoc at Michigan in medical decision-making, working with Angie Fagerlin and Sarah Hawley. And it's there that I actually got to do work on improving surgical decision-making for early-stage breast cancer. So you could say my whole life came full circle. But I'm now an assistant professor at Cleveland Clinic at the Center for Value-Based Care Research, led with our fearless leader, Michael Rothberg, who some of you may know. I'm fortunate to get to work in medical decision-making across a wide variety of conditions using decision analysis, implementation of clinical decision support, importantly, improving physician risk communication and promoting shared decision-making. But I did make the decision to leave cancer as a focus area. It was just a little too close to home. I'm currently funded by NHLBI to improve anticoagulation decision-making in AFib, and I have an R01 under review to improve statin decision-making. I feel just very fortunate to be able to use my experiences of decision-making in cancer to help patients make complex decisions to lower their stroke and CVD risk. So thanks, that's my Twitter, and I welcome emails and comments at the end of this.
Oh, thank you so much, Dr. Martinez. That was amazing. I think some of the things you said are your experience alone, but I think some of the things like about the means and the medians and your approach to decision-making, I just thank you for all the work you're doing for the field, and everything you've gone through is really helpful. So thank you for everything you've done and for speaking today. So we'll next turn it to we'll be hearing from kind of a healthcare perspective. We'll next be hearing from Lindsay Milner McNeil. She's Associate Chief Analytics Officer at St. Luke's Hospital here in Kansas City, to talk about how patient experience motivates transformation of healthcare delivery. So the floor is yours. And I guess while you were transitioning, if anyone has questions, please do put them in the chat. We will have a little bit of time for some Q&A and discussion right at the end here.
Okay, well, Stacy, I'm just gonna go ahead and say.
I think you might want to do the display setting swap. We see your presenter view.
There we go. Sorry.
No worries. There you go.
I am highly offended that I had to follow. Catherine, you did a phenomenal job, and I have so many questions myself, so now I'm gonna have to refocus here. So it's nice to be able to be here as part of this discussion. I'm gonna kind of pivot the discussion a little bit probably a little more aligned with Mary Kay's review earlier in regards to patient experiences, not as heavily focused on the patient reported outcomes, but definitely welcome the conversation. So just a little bit of information and background. When we're talking about patient experience, in the healthcare sector, providers for decades have been assessing a patient's experience in many different modes and many different ways, and across the entire continuum of care. And just as a background, since we're really kind of focused today, one of the questions that was asked of me is to focus a little bit more on HCAHPS. I wanted to give a little bit of background about that before we dig in. So while we have been, really assessing and seeking feedback from our patients for many, many years, in 2006, CMS introduced the requirement for participation for IPPS hospitals to collect feedback in a standardized mechanism through HCAHPS. HCAHPS is actually, the terminology is representative of the Hospital Consumer Assessment of Healthcare Providers and Systems. There's just many lovely analogies here that you can start to focus on this survey. It's a very robust survey itself, but CMS wanted a way to standardize the collection of this feedback and start to normalize some experiences that patients may have across providers across the nation. This really is a focused survey on our inpatient population only. There's many caveats, many exclusion criteria. I'm not going to dig into that in the interest of time, but the tool itself is really focused on the perspectives of care provided, that common methodology of just your general satisfaction. So it is truly trying to derive an individual's overall experience and not just their satisfaction itself. The standardized approach was really the first in the introduction to the risk-based payment model for healthcare providers. So again, it was referenced earlier in regards to why we don't do more patient-reported outcomes assessments. This is really that introduction of the financial implications and how those two tie together in the provider sector. What HCAHPS really assesses overall, they have a core survey of 29 elements, and those elements really consist of many different questions related to communication of the providers, whether it's the clinicians themselves, the nursing staff, their overall responsiveness, how the patients experience the discharge readiness and their transition of care. And then your general hospital operations oriented questions on room cleanliness and quietness, the food service delivery process, and then your aggregate ratings to try and assess your overall experience in relation to the hospital care that was provided. And then whether you as a patient would recommend that particular provider to your family and friends. And that's really a crucial metric for us to understand from a provider sector, because we do know how frequent word of mouth and really recommendations of our peers and our family members and our cohorts really drives a lot of our decision making when it comes to care. One of the unique factors of the HCAHPS survey itself was the actual rating scales that were introduced. And again, this was the first time that we really saw a focus as an industry onto a lovely 11-point scale. I always talk about it. One of those scaling situations that was really difficult for many of us in the provider sector to wrap our arms around. Well, how do you shift an individual that gave you a 7 to an 8? So it really gave us a little bit of a broader look at patients' experiences and gave us the ability to focus in on the different cohorts of individuals to try and understand what was driving each of these categorizations. When I talked about the fact that this was really the entrance into value-based care and pay for performance, I wanted to put into focus the representation of the fact that when in 2006, when CMS introduced HCAHPS, they were really starting to introduce the ability for us to shift from the perspective in the healthcare sector, from paying for just general participation and paying for services to truly that value-based and risk assessment based on your performance as a healthcare provider. CMS then went down the path of assessing how do they review the overall performance of providers, and they built out an algorithm called value-based purchasing. This is the particular calculation itself and some of the metrics that are behind value-based purchasing. And I could probably give, an hour-long presentation about the intricacies of this particular calculation, but just the overall understanding of the fact that the patient experience feedback that is collected after discharge when a patient leaves our care makes up about 25% of this total algorithm. The other components that come into play is our overall performance as providers in certain outcomes such as safety metrics, efficiency and cost metrics, as well as overall clinical care metrics related to mortality, readmission, things along those lines. So they're trying to take that full picture at a total outcome approach and start to assess the potential risk that providers may be putting our patients. The CAPS program itself, again, was its first introduction in the inpatient setting for HCAPS. Hospitals and health systems have digested this data and really started to address individual concerns. And I'm going to get into how we use that data here in a moment, but it's really focused right now on the inpatient sector. What CMS has started to introduce is similar survey methods across the other continuums of care. So as you can see here in this list, they're already starting to do similar CAPS-oriented surveys in some of the post-acute settings for home health and hospice individuals. We also have nursing home and resident-oriented surveys. We have outpatient surgery-focused CAPS surveys as well. And then they've just initially focused on some new ambulatory focused surveys because there for a while they had introduced a clinician and group CAPS oriented survey, but it was quickly replaced with a couple different alternatives because of the different care models that take place in the ambulatory setting. And so some new surveys that they're starting to roll out, still in testing, still in baseline mode, include PCS-PACS and the MIPS program as well. So how do we take and digest all of this data that we are now required to be collecting and that CMS collects up and starts to normalize and digest? Well, as a hospital provider and a health system provider, we really have to be focused on not only the results that we ingest internally from that feedback, but also the scores that are presented externally through the benchmarks and comparison. I know that it was referenced earlier, and I've got a quick depiction here in a moment about the changes that we started to see in some of the patient experiences scores nationally since they've been collected. And quite honestly, there's been a pretty big increase in certain composite areas where we've seen great performance nationwide. But what our goal here is not just to collect feedback to check off the box for financial reimbursement reasons. We need to be collecting feedback to continue to improve our processes and improve the care delivery. So as far as how we collect this information, we need to be able to introduce changes that focus more on efficiency in our care delivery process and encouraging patients along their journey. We also want to give patients the opportunity to continue to research their care options. And I think that was highlighted, in the patient outcomes example that was just shared. But even on the experience, we're starting to see patients be a little bit more of a consumer themselves, do their due diligence, understand how providers actually compare in their markets. And the use of this feedback data is absolutely where they're starting to get that information. Hospitals, like I said, they're seeing increasing scores nationwide, but also in their own markets. Their markets are becoming even more competitively focused on the patient's experience through many different initiatives and action plans that they have implemented based on the feedback scores and the feedback directives that have been given. We're starting to see the implementation of whether it's through different bedside reporting, different shift change handoff protocols, also introducing nurse navigators into different care settings that we haven't seen in the past because we're hearing feedback from our patients through the collected information regarding some of the communication and inconsistencies in their delivery of care. The responses themselves are really requiring hospitals to set up accountability structures. So we can't just collect the data and then say, well, now what do we do? Accountability is really crucial, and you're starting to see healthcare providers set in place through chief experience officers, through the use of PFACs, which is the patient and family advisory committees, to really continue to garner this information and identify the opportunities that they need to improve on based on the feedback itself. We're starting to see some substantial variation between the overall quality outcomes that I highlighted just a moment ago that are part of the value-based purchasing components, along with strong performing experienced hospitals in comparison to their lower performing experienced peers. One of the reference points was discussing about why and where we're starting to see some growth and why hospitals are so focused right now on continuing to improve their patient centeredness within their health systems. This is a great depiction of, since the overall HCAHPS program initiated nationwide, as you can see, each of these composite cohorts of questions have started to see a really strong increase in the overall scores for their national averages. I know that Mary Kay referenced, that we've not seen a huge increase since 2007 or 16 in the overall rating. I would completely agree. The data is showing that it's kind of started to plateau a bit in that overall rating of experience, but definitely in the areas where we have tactical responses and action plans as providers, we have still seen some great increases in common areas. 2020 and 2021, obviously, we know what's been going on in our care settings, and we have seen national information that we've seen drop off in the overall patient experiences that providers are trying to react to accordingly. So as I referenced earlier, there is a strong relationship not only with how we operate as a health system, the engagement level that our employees have and engagement level that our patients have, but it all ties back to the overall quality of care we're providing to our patient population. And this is just a great depiction of being able to show the comparison between high-performing hospitals that are in that top quartile of performance in relation to their HCAHPS scores in comparison to bottom quartile performing hospitals, and where you can see really the stronger outcomes that are being provided to their patients. So here you can see, we're seeing a reduction or 14% lower Class C rates in hospitals that have top quartile performance in their overall patient experience scores versus bottom quartile performance. Same thing with C. diffs, lower length of stay, lower CAUTI rates, I apologize. But again, the positive here is it's not just related to increasing your patient experience scores, but it's the overall approach to your patient centeredness. I'll focus really quick and then I'll end because I know we're very close to time. But how do healthcare providers really take in this data, ingest the data that we're receiving from the feedback mechanisms that we're collecting, and really what do we do to transform care? And it's really 4 steps. First you have to track and trend it. Many of us have been surveying our patients for many, many years, but we've got to have the mechanism to be able to ingest that data internally, start looking and stratifying across units, across providers, across subsets of our demographic patient population to really start understanding where we have some potential opportunities to improve. From there, we have to analyze deeper. An example is, when we've noticed we had an issue with nurse communication, our CNOs have got on board and said, okay, what are we having issues with in the nursing communication area? We identified that our handoffs weren't necessarily as coherent as they should be between our nursing shifts, and how do we to correct that? They've put in place some different action plans and mechanisms surrounding supervisor and leader rounding during the handoff shift time, documenting on boards in the rooms and talking and having very purposeful conversations about care handoff in the presence of the patient. So those are just some examples from a best practice standpoint that we worked through as we leveraged this data to continue to drive the change in how we care for our patients. And then the last piece, after you've really identified and tracked the data, identified your opportunities to improve, established some action and drove change, is really continue to monitor for success of those implemented plans and see if you need to revert and introduce new process. What we're seeing, and as we work with our patient experience vendors, as well. Those keys to success for providers are really the accountability structure is necessary. I think in many areas, we feel like as long as we're monitoring the data, we'll be able to react. But not having accountability through whether it's a service excellence group or key physician champions that are really driving change in their practice or their division, it really creates it difficult to hold individuals accountable to continuously monitor and continuously improve. And then we also have to drive a culture of change. And that's what we've seen from a success standpoint here at St. Luke's Health System is really creating service excellence into a culture. And then the last piece I mentioned earlier is introducing and engaging patients and families into the mix of our overall experience program. And that's really seen and been successful through the methodology of leveraging PFACs, which are the patient family advisory committees that are in place across our health system to allow individuals that are a little more engaged in their care the opportunity to help us assess before we pilot potential implementation for change. I wanted to just highlight a few areas that we've seen here in research standpoint where the overall experience itself is truly being related to patient reported outcomes as well. So we've talked quite a bit from a patient reported outcomes, and obviously those are collected through many different mechanisms, but the correlation between the overall feedback and the formal patient experience programs and what is seen in the patient reported outcomes has been tremendous in the areas that they focused. I know I flew through that. I apologize if I missed a few pieces.
Great. Well, thank you so much, Lindsay. That was really great. And I think just hearing a little more about, HCAHPS, the role in which, a healthcare system uses, satisfaction, primarily from the patients in different areas of care to continuously do quality improvement. I think that's really valuable and important. I'm trying to think of, the way in which, so I feel like once you unpack the satisfaction, though, I do think this is kind of where, Dr. Martinez's work comes into play, is where it's a really multifaceted approach of like what truly gets at satisfaction, right? And then when a patient is facing a really serious, decision where they need a lot more support or they need things tailored to their own risk, sociodemographics, values, preferences, I think, that's where I think many of us struggle. And I would love to, I put a really long question in the chat, but I would love to also ask it, just to get, Katie's perspective on, how do we best kind of move forward, knowing that, with the world we operate in and this, we're still in a little bit of fee-for-service kind of transitioning slowly into value-based care, but where can we find ways to better integrate, patient preferences, and not just patient preferences, but as you kind of mentioned, true patient risk profiles. So, that we truly get exactly, what every individual patient needs. So it's very patient-centered. And I just love to hear your reflections on how we move into getting that into care more regularly with payers, with, healthcare leaders, with CMS, et cetera.
I mean, you have an example like the Watchman, where you have CMS basically saying that we aren't going to pay for this unless you do shared decision-making, right? And do informed decision-making with the patient. So you can mandate it like that, but then you wind up, having these inadequate shared decision-making conversations. And so it's kind of like, it's kind of the only way to sort of compel physicians to do it, like from a financial standpoint. I think that there's just a whole complicated philosophical debate about which decisions sort of are highest priority for these sorts of conversations and which are lower priority. Luckily, since I went through treatment, it's pretty standard of care to engage patients in some deliberation around surgical decisions because it's such a high stakes decision. But now in the space that I'm working in statins, right, physicians don't want to engage patients in shared decision-making for statins because they just want to prescribe them statins, and they don't want them to entertain any weird preferences based on, some patient-reported outcomes that say, 50% of patients have muscle pain when the physician doesn't even believe that's true, and it's not true based on these other studies. I think that there's been this whole issue where physicians want to use informed decision-making when they think it will compel patients to make the decision they want them to make. And they don't want to use it in the cases where they think the patients might make the wrong decision. And so come to Society of Medical Decision Making, we're always debating this. But I think from a payer perspective, you have to mandate it to get it paid for. But in primary care, where screening decisions are made, that's just never going to happen.
Pose the question, as you talked about the collection of the patient-reported outcomes, it really wasn't highlighted today, and I would wonder what your take is here. The introduction of bundled payments that was attempted a couple of years ago when we're talking about joint replacement, they introduced requirements surrounding the collection of patient-reported outcomes through the WHO's promise surveys, but we've really not seen anything else come into fruition with the collection of that data. We're still just reporting it, but it's not really being leveraged, and it wasn't leveraged as part of the payer process. So I would wonder if anyone has been focused on patient-reported outcomes in relation to that particular use case.
Anyone in the audience have comments?
So I feel like that was kind of the first, a more global approach. Payers were in the process as well. It was a bundled payment model and requirement of the collection of the health outcomes data. But we've not seen that continue. First of all, the bundles went, kind of away, and not seen that same structure in any other.
You're gonna figure it out. You're gonna figure it out. She's here. Yep.
Lindsay, I'm curious, when you provide these high-level data, at your hospital, I mean, I imagine that there's a lot of sort of, I don't know if you get the data at the level of the clinic or the level of the unit the patient was cared for, since they're blinded data. How do you engage the clinicians, the nurses, the physicians, et cetera, to take the data seriously and to really strategize about how they're going to direct? It's one thing to do benchmarking. It's another to leverage those benchmarks into change. How do you create that opportunity at St. Luke's?
We've seen over the years, Dr. Spertus, this has been a lifelong journey for us here, but it absolutely started with physician engagement at the highest level. So, with many operational changes, you start out at an executive level, understanding how potential scores and feedback may be impacting your overall experience and care delivery process. And then you start engaging your director of patient care services, your unit managers, physician champions themselves who have a passion for patient experience. So you can really make the case for the why. So what we've done over the years, especially, is through the identification of opportunities. Years ago, we had an area where we felt like we should be improving our communication with physicians composite score, and we knew we had some issues with bedside relationships with our patients and our physicians themselves. And so, we set forth task groups with key physicians, through hospitalists, through specialists, identified what those communication barriers were with our patients, and established a training program to kind of re-educate why it's important to ensure that your patients feel that respectfulness, that you're listening to them, open those lines of communication, and then even, researched a little bit further on some best practices of physicians sitting down at eye level when they're communicating something very impactful to the patient themselves. So once we re-educated our physician workforce, and a lot of those were done through our general, health stream education, and we set up, it was back when Dr. Pegels was here, helped lead the way with some of that education. Then we set forth some standard criteria that physicians then had to start meeting certain goals. Again, layering in that accountability for them. So it started with identification of issues from the data itself, but then we were able to start impacting the way our physicians interacted with our patients from that process.
Stacy, I'd like to comment. It's Mary Kay. What we find is when we collect feedback from patients and share it back with the client, the client feedback is they never hear topics of conversation from patients that are a surprise to them. What is always surprising to them is the relative importance of the different topics that patients are reporting on. I'll give you an example. One client, wait time really came to the top, and it was an issue across multiple departments. And so they decided to start working on it. And one of the ways that they engaged the clinicians in helping to solve the issues was to share with them the feedback from the client, from the patients. And initially there was a lot of resistance, but when they started to see what their own patients were saying about the problem, it was tremendously compelling. And the other thing is, once they began to make interventions, the patient feedback on the interventions popped into the feedback from patients because, for example, one client installed an application so patients could register in advance and wouldn't have to wait in the waiting room. They could sit in their car or whatever. But the people who were waiting in the waiting room saw all these other patients coming in, and from their perspective, they were jumping the line. And so that was really valuable feedback to the team that was making the intervention. They more broadly communicated what they were doing, and it solved the problem. So my point is, you can use patient feedback very effectively along the way to help indeed get clinicians involved and to help shape the actual intervention you're going to make and ultimately the success of what you're doing.
Yeah, I think that's an extremely powerful example of showing just the ways of which, it's along the same vein, right, of where the physician report cards or sharing HCAHPS scores, holding them accountable to it, but the way in which you hold or show and demonstrate the data back to the care providers, they really do kind of understand and see and hopefully make changes. And it also leads to a lot of the other area where we've gotten a lot deeper in the QVIC, which is, implementation science and how you finely tune to identify, it's that marriage of quality improvement and using implementation science from more of an academic perspective. But in order to find ways to truly identify what are the true barriers and facilitators and what are we seeing as we roll these interventions out into clinical care, and how can we make them better so that they are helping, all the stakeholders. And so, anyway, I wish we had a lot more time for discussion. I want to be really respectful of everybody's time here. This has been an extremely powerful forum today, and I just want to thank all of our speakers. I loved hearing there were so many great snippets. I was writing them down and emailing them to myself. But that all of these aren't, they're not just they're not just surveys, and they're really tools and ways for us to improve care and outcomes for patients. And I really loved, just the perspectives everyone brought. So I just want to thank you all. These are recorded and on our website. So if anyone wants access to them, you can get them in the next few days. And we'll be rolling out, just for everyone that's aware, we'll be rolling out our 2022 forum schedule in the coming weeks. But I do, knowing that we do keep these monthly, I wanted to let everyone know that our next one is January 20th, and we're already getting a really great lineup of speakers, both regional and national. And it's on teamwork and communication approaches to support workforce well-being and performance. And so it's a little bit of a mix about how teamwork improves overall performance, but also, knowing that everyone is in many fields very burnt out. How do we also support the well-being aspect through different teamwork and communication approaches? So that's on January 20th. Mark your calendars and you can register on our website. And thanks again to everybody.